Well, welcome everyone. Welcome to Mistakes to Avoid in Glaucoma Management. We have the privilege tonight to have Dr. Joe Sowka do this lecture. Joe is, in a sense, an expert in this arena. And Dr. Joe Sowka is an attending optometric physician at Center for Sight in Sarasota, Florida, a large medical surgical practice where he focuses on glaucoma management and neuro-ophthalmic disease. He was formerly a professor of optometry at Nova Southeastern University College of Optometry for 28 years, where he served as the chief of the Advanced Care Service and the director of glaucoma service at the college's Eye Institute. He was the program coordinator and supervisor for the ocular disease residency. Dr. Sowka is a founding member of both the Optometric Glaucoma Society and Optometric Retina Society. He is also the founder and chair of the Neuro-Ophthalmic Disorders in Optometry Special Interest Group for the American Academy of Optometry. Dr. Sowka is a glaucoma diplomate of the American Academy of Optometry. And in 2021 and 2022, he was ranked number 4 optometrist by the U.S. by Newsweek magazine, America's Best Eye Doctor list. He is a partner and co-owner of Optometric Education Consultants. And with that, Joe, please give Joe, my friend, our colleague, a big virtual round of applause. Joe, it's all yours.
Thank you, Greg. Welcome, everybody. And as Greg mentioned, I'm a bit under the weather. I've been actually fairly sick since Thursday. I've got a pretty bad case of laryngitis, but I am just plain old-fashioned sick. It's just a cold. I tested negative twice for COVID, 2 different tests. So I didn't know that was an option, Greg. I didn't know you could just get sick. I thought it was only COVID or nothing at this point.
I think you should just say it's COVID, Joe.
Yeah, I am, but I know we have a lot of people here. This is one of our larger webinars. You made time to be here, so regardless of how I feel, the show must go on. So this is a picture of Sarasota. This is where I live. I work for Center for Sight, which is under the umbrella of USI. It is a multidisciplinary OD-MD practice, concentrating in medical surgical eye care. Now, these are my disclosures. I've been on the advisory boards for a few companies, but all relevant relationships have been mitigated. I've got no financial interest in anything we may talk about, and I'm a co-owner of OEC with Greg. So here are a number of mistakes that we don't want to make, and these are not even all we're going to talk about. But we don't want to make the mistake of not recognizing a neurologic visual field, thinking glaucoma causes optic disc pallor, diagnosing non-arteritic anterior ischemic optic neuropathy in glaucoma patients, not recognizing when the OCT is wrong, treating red disease and not treating real disease, changing therapy based upon one bad IOP or one bad field, not getting enough pre or post-treatment IOPs. And I want to wrap up with recognizing what patients will likely do well and whose are not going to do well, and not the patients you may think that they are. So mistake to avoid is not recognizing a neurologic field. Greg, this brings you right to polling question number 1, if you don't mind launching that, or you want me to get that? Oh, you got it. Good.
I got her.
So what visual field defects suggest something other than glaucoma? Vertical oriented, paracentral defect, arcuate defect, or a nasal defect?
And Joe, I think I'm going to go see if I can find the handout.
Very good.
And place it into the chat box. That's usually my reminder to when we do a polling question. So do you have the polling question there, Joe, to end?
I am good.
Okay.
All right, we've got a lot of people still weighing in.
I'm going to find this handout.
All right, great response. I'm going to end the poll. I'm going to share the results. And the majority say a vertically oriented field defect. And the answer is yes. When you have the chiasm behind chiasm, you have to look for the verticality of it all. But when you're in the orbit, you can have arcuate and nasal defects. 74-year-old female was diagnosed with glaucoma in Jamaica. She had run out of medicine. She comes in, her pressure is 20 in each eye. She's 20/50 right eye, 20/40 left eye, well explained by her 2+ nuclear sclerotic cataracts. Pupils reactive, there's no afferent defect, and she looked like this. So as we take a look at it on the OCT, you can see that there is some pronounced abnormalities in the retinal nerve fiber layer of the upper left. There is a relatively poor ganglion cell complex in the upper right. Now we take a look at the optic nerves. There's some thinning of the inferior rim tissue in each eye. The rim tissue is pink and perfused. There's no pallor. We can see some ophthalmoscopically visible nerve fiber layer defects. And this really makes a lot of sense for glaucoma. So I run the visual field, and this is the field that I get. And one thing I want to point out, a couple pearls here. When looking for glaucoma or discussing glaucoma, on the visual field, one of the first things you want to ask is, where is the nasal defect? And we can see it here, a nasal defect, not much of a nasal defect here. And we've all been conditioned to look at the pattern deviation for the true retrolenticular visual field loss. But what I want to do is I want to direct your attention to what we don't look at, but should look at, and that's the grayscale. And one thing I see here is a blind spot breakout that goes to the vertical and stops. So I look over in the other eye, we have a defect that really crosses the vertical, but if you look at it, there's a different density on this side compared to this. So this looks to me to be a bitemporal defect. Here's a hole within the hole, so to speak. Now I will tell you, every year, just by coincidence, I will get a handful of patients with glaucoma accidentally turn in a neurologic looking field. I never worry about it. First thing I do is repeat it same day or bring him back. And I repeat it. And if we just look at the pattern deviation, we miss the bitemporal defect that is hiding underneath the glaucomatous defect. And this is a patient who had a large suprasellar mass. She had a large pituitary adenoma. So we don't want to miss looking at the grayscale. Here's a 65-year-old female. She's got glaucoma both eyes. I don't know what her peak IOP was. She comes to me on latanoprost, and she's had SLT. Now take a look, and she's got a very compromised nerve in the left eye with some degree of collateral vascularization. In the right eye, we can see some compromise to the nerve tissue. I can see a nerve fiber layer defect right there. The nerves are not pale. Her vision is not reduced to really in any way significantly. And this looks like a pretty good cut, clear-cut case of glaucoma. Now, if we take a look at her on the visual field again, we're all caught, conditioned to look at the pattern deviation. And it looks like I've got an inferior arcuate defect with nasal loss here. I look on the other side, I see nasal loss superiorly. It matches anatomically what I expect to see based upon the nerve. But again, don't forget to look at the grayscale. So we take a look at the grayscale, and I see that, but I'm really troubled by that defect right there that stops at the vertical. So I look over here. Yeah, there's a large arcuate defect, but look at the density here. This is an area of less than 0. When we compare it and look at this and this, we are now looking at a right inferior quadrant defect. Oh, and by the way, and this is exactly the kind of patient that I'm going to neuroimage. Oh, by the way, while I was getting her neuroimaging, she called and reminded me, I just remembered, about 10 years, I woke up one day and I couldn't speak for several hours. I prayed and my speech came back. So this is a person who actually had a TIA. She's had a retrochiasmal lesion. This is a person that I did get imaged. She had evidence of an old stroke, and she got referred to stroke neurology because she's had TIAs and an actual silent stroke. Now, here's a person who's referred to me from a colleague in my practice. This was not a glaucoma suspect. He was a 53-year-old male complaining of a blind spot in his left eye while driving. And my colleague, worrying about neurologic issues, did a full field 120-point suprathreshold test. And we take a look at it, and it really doesn't give me a lot of information. I mean, the guy only saw a very few points, and it looks like, based upon the pattern, it's mostly nasal loss. So she felt uncomfortable, asked me to take a look at the patient. Now, as you look at the pattern deviation, it is so horribly depressed at 5% and 28%, it doesn't give us any useful information. However, if we look at the grayscale, don't forget to look at the grayscale. It's very, very dense here. I look over here, it's very dense, but look at that special density respecting the vertical. I come over here. This is exactly the kind of person I'm going to neuroimage. It turned out he had a very large brain tumor. 53 years old, I was not thinking stroke. I told him what my suspicions could have been. I believe he's actually doing well. He's had a craniotomy. His wife has called twice and left messages thanking me for pursuing this and finding his brain tumor. So don't forget, look at the grayscale. It's very helpful in identifying neurologic issues.
So, Joe, what you're saying there is latanoprost is not going to treat that brain tumor?
No, it is not going to treat that brain tumor. Now, what optic disc feature suggests something other than glaucoma? And keep in mind, two of those patients I just showed you, they had glaucoma and something else. So what suggests something other than glaucoma? Is a disc hemorrhage, disc pallor, disc notching, parapapillary atrophy.
Joe, I don't want to steal your thunder on this, but you've gone through a couple visual fields here, and I like the acronym, PITS. Visual fields are the PITS. Are you going to be reviewing that in an upcoming slides?
I think so. Do you want to do it?
Yeah. So I'll just take care of it here. Is Joe's showing these visual fields, these quadranopsias here. I try to remember the acronym. Visual fields are the PITS, parietal, inferior, temporal, superior. So he still has that visual field up. It looks like a superior quadranopsia there. The one side looks like a hemianopsia, but superior worse. Visual fields are the PITS, parietal, inferior, superior, temporal. Whenever we call to do that MRI, we want to give maybe someone a little special attention to that temporal lobe, since we got a superior defect there. So just remember, the visual fields are the PITS.
Now, one thing, we all learned that anatomically, that's a great mnemonic, but actually temporal lobe lesions are kind of uncommon. Almost all of them, either superior and inferior, they often usually end up in the parietal lobe, something usually there. All right, so we end the poll and share. Okay, so the majority of people say disc pallor is indicating probably something other than glaucoma, and I think that's a great sentiment. I think y'all got that one pretty well right. So here's a mistake to avoid: thinking glaucoma causes optic disc pallor. Now, I was doing a live meeting this weekend, and some of the audience got into an argument with me, and he said, "No, glaucoma causes pallor." And I try to tell him it doesn't. Don't make me spank you. This doesn't cause pallor. So yeah, I mean, my end stage cases are all pale. The ring tissue isn't pale; it's scleral tissue. You're looking at a 95% cup. But I'm talking a 60 or 70% cup, where you actually see pallor with neuroretinal rim. So a rule of pallor in excess of cupping indicates something other than or in addition to glaucoma. That's a rule number one to follow. But rule number 2 to follow is nothing notches a nerve like glaucoma. Trauma doesn't do it. Tumors doesn't do it. Demyelinating disease doesn't do it. Infection doesn't do it. The only thing that really causes that cavernous atrophy and notch of the neuroretinal rim is glaucoma. Now, I often get asked the question, we got OCT imaging. Do we really need to do visual fields? Well, he's a 54-year-old man who has referred me for glaucoma management. He had been told he had glaucoma 6 years earlier, but underwent no treatment. I don't know why. He had about 20/30 in the right eye, hand motion in the left eye. His previous doctor said, you've got vision loss from glaucoma. It's not coming back. We have to maintain your existing vision. So he's got 30 pressure in the right eye, 23 in the left. He's put on Lumigan and referred to me with now a pressure of 17 and 15. And he looks like this. And he's got large nerves. He's got large pups, probably about a 0.7 to a 0.8 CD ratio. But a 0.7 to 0.8 CD ratio does not explain hand motion vision. We can see the right nerve is pretty well perfused. We make comparison to the left. It's actually fairly well pale. So he's got disc pattern in the left eye. He's got unexplained vision loss in the left eye. Now, on a old nerve fiber analysis, his nerve fiber layer is actually pretty normal in the right eye and only moderately abnormal in the left eye. So you may think, do we really need to do fields? We've got a nerve fiber analysis. We have pressure risk factor, and we've got optic nerve cupping. Isn't that enough? The answer is no, because these are his visual fields. And what we can see is a bitemporal defect. And he had a pituitary adenoma that was actually so large, it also compressed the posterior aspect of the optic nerve. So that's why he had poor vision in optic disc pallor. So clearly, we do need to do visual fields, even the age of OCT imaging, because sometimes it's not glaucoma. And fields will tell you when there's something neurologically wrong. Now, that's a lot of stuff to remember. If you can't remember that, I'm going to show you my ode to a cup disc. Ode to have a cup disc pink, that, my friend, hath a glaucoma stink. But to have a cup disc pale, called as glaucoma shall fail. Disc and field damage that's one-sided simply cannot be abided. There might be traumatic infarct or meningioma, but if the rim is cut, always remember, nothing notches a nerve like glaucoma. And if you can remember that, that will keep you out of trouble.
Hey,
Go
Joe,
any questions? Yeah.
Yeah, that was perfect timing. We do have a doc asking, when you order an MRI, do you have it go through the primary care physician normally, or order it yourself and have them go to an outside imaging center, ? Then refer to primary care physician and neuro after?
Good question. When I'm doing serology, blood work, blood studies, I always work with primary care physicians. When I need neuroimaging, I get them myself, unless there's a reason why I have to go through the primary care physician. Because if I do, they usually ask what to do. So I'll get the imaging myself because I know what to look for and how to look for it. Now, based upon what I come up with, I make the referral. It could be primary care physician, it could be neurosurgery, it could be neurology. And I will tell you, when I have positive imaging, it makes it a lot easier to get them into a specialist once you know what you have. But I do the imaging myself, serology, with the exception of testing for giant cell arteritis. I do that with a primary care physician. Now, if the PCP has an imaging center or is in a facility that has their own imaging center, I may work with them that way too.
And I'll add
Right.
to the well, I'll launch the poll here, and that'll be a good little filler while we're doing the poll. I agree with everything, Joe. Serology, work with the PCP. Sometimes they already have it done. The only caveat I'll add is, yes, they usually want to know what to order. So ordering it yourself, working with the imaging center, telling them what you're thinking, parietal lobe, superior lobe, occipital lobe, helping them left side, right side based on the visual field. But I just usually call the PCP because sometimes you can start maybe figuring out some more history from what the patient might not have told you. So
Excellent.
really nothing more than at that point, I'm notifying the PCP what's going on. Sometimes you can get some more history from it.
So what I enjoy about being in my facility is we all work together in the healthcare system. So what conditions least likely occur in a patient with glaucoma? Is it a vein occlusion, cataract, non-arteritic ischemic neuropathy, or AMD?
And I think we're all caught up here on our questions. So remember, everyone, this is interactive. So put your questions there. The polling questions make this interactive. And we're getting to a respectable number here. We got someone coming in. Let me admit them. And we good, Joe, on your end?
Yeah, we're good.
Okay.
And the number one answer is non-arteritic anterior ischemic optic neuropathy. And I would agree with you. I'll explain. Let's go into our thinking about that. Here's a mistake to avoid diagnosing non-arteritic ischemic neuropathy in glaucoma patients. It's not a good combination. Non-arteritic ischemic neuropathy for a lot of people is a great diagnosis of convenience. I mean, there's no test that conclusively diagnoses it. There's no treatment for it, so there's nothing you actually do for it. It has been used as a great explanation for pallor in a glaucoma patient, but always remember, 97% of non-arteritic ischemic optic neuropathy patients have a CD ratio of 0.2 or less. And I think the other 3% were misdiagnosed. So this is a disease of non-cupping, whereas glaucoma is a disease of cupping. And these are people who have that small, crowded, disc at risk, virtually no cup to disc ratio, small nerve, not much room in there, and they infarct. This is exactly the kind of patient I'm going to neuroimage. So the patient with pressures in the 30s. So you can see large CD ratio. But what I don't like is the fact there is a pallor from 12 o'clock to 3 o'clock. And it doesn't look the same in the other eye. We have a nice inferior arcoscotoma. This is the kind of person you want to call glaucoma, yes. But another practitioner said, yeah, there's pallor, but you probably had a stroke in the eye. You had ischemic neuropathy. This is not the kind of CD ratio that puts a patient at risk. This is exactly the kind of patient that I'm going to neuroimage, and she had a posterior orbital tumor. Mistake to avoid, not recognizing when the OCT is wrong. It's not a Silicon Valley Rumpelstiltskin. You just don't put in straw and get out gold. I think the use or overemphasis of any imaging technology, if you exclude other clinical findings, it is very risky. And people ask, how much confidence should I have as to whether an OCT will tell me whether or not a patient has glaucoma? And my response is, how much confidence do you have before you image the patient? It shouldn't completely change your opinion. There are many issues in imaging. There's a normative database, which is not as robust as you may think. You've got to deal with signal quality, blink and saccades, segmentation errors, because these devices don't always measure the tissue the way you think that they are. You have to consider medial pacification and the aberrant axial length, the high hyperope, or mostly the high myope. So what are we going to be looking for? You want a good quality score, whatever is dictated by the manufacturer of your equipment. Make sure it's well illuminated. Make sure it's nicely focused. The image is well centered. Look for any sign of eye movement. Make sure that it's segmented well. Look at these B scans. Make sure they're well centered. Look for any missing data in the printout. Consider media pacifications will lead you astray. And of course, if you're going to be looking at the ganglion cell complex in the macula, you've got to look at the B scan for any maculopathy that will affect your results. Nice example here of eye movement. And we see that when we see the sharp delineation on the en face imaging, it means there is a quick eye movement. Now, I can look at this, I may actually get pretty decent results. But if you're putting this somewhere in a guided progression analysis, you're going to have some issues. It's going to throw off the guided analysis. So you've got to look for the signs of eye movement. Greg, how about poll question number 4?
Joe, I was helping one of our attendees get in. So I'm not sure. It's 5:29. A question came in and said, what about VA? So I'm not sure. That was about 3 minutes ago in one of your slides, just whatever you were. So I was trying to help someone. So it says, what about visual
acuity? The question might have been, what about VA for the other patient with a disc pallor? Actually, VA is really good. It not been compromised, at least yet. So conditions can get, most likely give aberrant, unusable information on a ganglion cell analysis on the OCT, moderate myopia or hyperopia, or epiretinal membrane and acido hole.
We got some further information. It says that was in regards to the non-arteritic ischemic and disc pallor.
Yes, the visual is actually quite good.
Okay, I think we're caught up there. My person is in, and we got a polling question. Okay.
We had a good response. I'm going to end the poll and share the results. I think most people agree that some sort of maculopathy, epiretinal membrane or acido hole could affect our results. And I would agree. Here's a patient that we're being examined for glaucoma, and we can see that there is some abnormalities here in the ganglion cell complex. But when we look at the B scan, you can actually see they have central serous choroidal retinopathy. I accidentally found that. I mean, I didn't pick that up even in the clinical examination. Here's 2 patients I actually saw in the same week. The ganglion cell complex doesn't really look that abnormal in the example on the right, but the complex looks very aberrant in the example on the left. And as we look at the B scans, we can see that there's maculopathy, and this patient has an ERM and a acido hole, and kind of about the same thing right here. So when we see the maculopathy, we have to use this with caution, or maybe not use it at all. Now, if you think that these machines are always diagnosing or measuring the tissue accurately every time, here's the patient. It's really a bit of a mess. There's missing data. There's a large PVD, which is being picked up as nerve fiber layer thickness. We're getting information cut off on the tomograms. Lots of vitreal floaters. Just a lot of misinformation in this. But the machine doesn't know any better. It does its best. Here's an example of an epiretinal membrane, which is being misdiagnosed as the internal limiting membrane. Now, this example is trying to show that thinks that the nerve fiber layer is unusually thick in this inferior area. And a paper came out about a year ago that looked at ERMs in patients, with glaucoma. They cautioned that you're going to get aberrantly elevated nerve fiber layer findings.
Joe, keep that picture back up there. Yes. And, that same area around that optic nerve, remember that the posterior vitreous or the vitreous is tacked down pretty tight in 3 different areas in the back of the eye, around the optic nerve, around the macula, and, out in the oris serrata. And, we do a lot of OCTs in the practice. A lot of people send OCTs for me to evaluate. And you remember in this glaucomatous age, that's about whenever there's glaucoma suspect age, that's whenever those PVDs are forming around the optic nerve. And I've seen people change, 15 to 20 microns, and people are like, oh my gosh, that's a lot of change. It must have some type of glaucomatous. But if you go back and you look at the scans like Joe has there, and you can see the pathology and you can see the PVD, and then the PVD releases, I think you can then quickly rule out that the patient doesn't have glaucoma, that their 15 to 20 micron change is not from a glaucomatous atrophy type of or damage. So I think Joe, the pearl here is, looking not just at the numbers, but actually looking at the scans at times can help out. And there you have a great epiretinal membrane, and maybe even a little traction over there right beside where your arrow is. So
Absolutely. That's a great point, Greg. And that was a great time for me to have a little coughing attack. So thank you.
I can feel it coming.
And always remember, it's never going to go to zero. You've got a floor effect of about 45 microns. If the nerve fiber layer drops to zero, there's something wrong, missing data. Or in this case, a segmentation error. The machine got confused as to where the ILM and the RNFL actually was and merged them together. Once you see something that drops to zero, we really can't use this information. And this is a patient of mine with glaucoma. She had pretty dense posterior vitreal detachments. And it kind of always floated somewhere else. It always got in the way of my photographs or got in the way of the OCT. It's trying to make it look like it has a very unusual disc shape. It's only because it's catching a PVD. But the machine doesn't know that. So if you don't look at the other pieces of information and you just look at numbers or colors, it's easy to miss this. And of course, remember, there's a floor effect. Once we get this low, we really can't use this information to follow the patient over time. And always remember, it never goes to zero. That means we have missing data or segmentation error. Unfortunately, I've seen clinical decisions made based upon bad data like this. Be very careful. It drops to zero. We're missing data. We've got a bad scan. Now, here's a mistake to avoid: treating red disease. This is a term that is more familiar to people today. But when we first started using it, people didn't understand. What is red disease? Oh.
Got it.
Thank you, Greg. This is a non-glaucomatous masquerade disease affecting, educated patients with good internet access and good health plans. It's debilitating to the patient and it's very painful for us. And this was first published in 2005, the Journal of Irreproducible Results in Census Studies by the great researcher, Dr. N.S. Sherlock. And this is where, when we started using these devices, patients would be diagnosed often by a company rep in an exhibit hall, where a doctor wandered in, they got imaged, everything came out red outside the normative database, and was said, you might have glaucoma. Now, here's an example of red disease on the HRT3. Here's the first visit. Optic nerve is scanned, the topographer is done, and everything falls within the normative data range. Now, first follow-up visit number 1, there are some changes. Things that were green within the normative data range are now yellows. We come over here, and now there are more abnormalities, and we are looking at possibly change over time. Now, the question is, how long did this change take? Well, it actually took 15 minutes. Just by changing where the contour line was drawn on the edge of the optic nerve. So there can be artifacts introduced in these tests. Here's a patient, low risk ocular hypertensive. The local optometrist wanted to get OCT imaging for baseline, didn't have an OCT. So image the patient for the person. We have a very good nerve fiber layer. Everything looks good on the B scans. Everything falls within the normative data range. And we do the GCC. It looks great in the right eye and looks terrible in the left eye. And my experience is you don't have the dichotomy of a good nerve fiber layer like this and a terrible ganglion cell complex like this. What do? Just repeat it. Same patient, same day, same quality. Now it's normal. And again, just look for the missing data and make sure it makes sense. Now, here's a patient, 62-year-old male, asymptomatic, 2020, pupils normal, had one isolated pressure elevation of 30 and 28 in our university primary care clinic. Now, I saw the patient over time for about 11 visits, never got anything nearly that high. But that's how he ended up in my service. Bone was normal, CCT is a little on the thicker side, and this is what we see here. Optic nerves look very good, no degree of significant cupping, no optic nerve pallor. But we do a nerve fiber layer analysis, and this was a GDX. We also did it on an OCT, looked exactly the same. Pretty good nerve fiber layer in the right eye, almost non-existent nerve fiber layer in the left eye, or inter-eye asymmetry. And I can tell you that when I see something like this, and Greg, you can share your experience here as well. When I see something like this, I expect profound vision loss in the left eye. I would expect probably a relative afferent pupillary defect. Greg, what are your thoughts?
Yeah, definitely. With the, when don't forget, whenever you're looking at the ganglion cell, the axon that comes out, and then it goes through the optic nerve and synapses all the way back at the lateral geniculate body, that's the afferent fibers. So when they're this symmetric, especially, I would look at that and say, okay, that patient should have a left afferent defect because there's enough afferent fibers that are damaged.
So pupils are fine and fields look like this. So I found the patient for about 2 years. I did visual fields every 6 months. After 2 years, nothing changed, dismissed. Now, here's a mistake to avoid: not treating green disease. This is a glaucomatous process masquerading as non-disease. And it usually is going to afflict people who want a machine to make all the clinical decisions for them. It is debilitating to the patient. It's painful for the provider, but it's a boon for malpractice attorneys. Now, here's a case where the diagnostic imaging didn't agree with the diagnosis. He's a 56-year-old glaucoma suspect since about 2012. He was seen by different practitioners at the university's general care clinic over time. His peak pressure was 32. He usually ran the mid to low 20s. Average pachymetry. Cup to disc ratio fluctuating depending on who was examining him at any time. Gonioscopically well open to ciliary body. And here is the OCT. Now I take a look at it, I see a relatively robust nerve fiber layer thickness map. I look down here, there's a few small departures from the normative database of borderline statistical significance. But in this area, there's a very large area in the glaucoma-prone zone that falls well outside the normative data range. We took a look at the ganglion cell complex. It is pretty robust in both eyes, all within the normative data range, but one looks maybe a little bit sparser than the other. And it seems to correspond to the sparseness of this nerve fiber layer. So there's a lot of things to look at. There is no maculopathy. Everything looks to be in order. These are our results. So it brings me to polling question number 5, Greg. What's the best assessment of this patient? Is the patient normal in both eyes, abnormal in both eyes, normal right and no abnormal left, or abnormal right and normal left? You notice I'm not saying glaucoma because you can't make a diagnosis based upon this. I'm just asking you, how would you interpret this OCT?
So Joe,
Yeah,
there's a question that came in to the chat that says, I was at a conference this weekend and the speaker said he does baseline testing on every cup to disc ratio 0.4 and above. What's your threshold? That seems pretty extreme, was the comment.
well, if you consider that the average CD ratio is 0.4, yes, I think that's extreme. I don't have a cutoff. I had looked at 0.7 and 0.8 nerves that were large. The rim tissue looked great, and I let them be. Now, if the nerve looks asymmetric or otherwise notched or thinned in the neuroretinal rim, that's my cutoff. But there's no number for me. And 0.4 CD ratio is average. So I agree that is extreme.
Yeah, I think it's extreme also. I think, we know enough now, and maybe starting off in your optometric career, maybe that's a good threshold to go by. So, there's different, I guess there's, different experiences out there, but, is that my threshold? You got to remember there's micro discs, macro discs, normal size discs, tilted discs. I think you have to learn to evaluate the optic nerve. So, I think it might be a good pearl to think about, but I think as you get more experience, I think you'll find I agree with you there. I think you put that to everyone, Kim, that, it seems a little extreme, but
yeah. All right, so we have a pretty good smattering. Most people say normal right eye, abnormal left eye. I think that's very reasonable. I mean, I don't think you can really look at this and make you say abnormal both eyes. But I think I think people had a very good assessment. So I take a look at the patient and I look at the area of question. The nerve looks actually very good to me there. I don't see any visible nerve fiber layer defects, but I come over here and what I do see is a large wedge defect. So let's go back. This area of suspicion was actually fine. This area right here is what actually showed up. And there it is. Not very impressive on the OCT, but very good on the red-free photographs. And this area right here was perfectly fine. Now when I look at all the visual fields that have been done over time, 1, 2, 3, 4, very consistent superior nasal defect that corresponds to the wedge defect on the photograph. And you look at the other eye, which had the more suspicious, it's perfectly normal. So he actually had glaucoma in the right eye and ocular hypertension in the left eye, or as I like to say, an example of red disease in the left eye and green disease in the right eye. And that's what I mean by green disease. Here, there is a visible nerve fiber layer defect. When we take a look at it here, and it doesn't really show up. And everything falls within the normative data range. Now, one thing that you may point out or notice is superiorly, there's very good symmetry. Inferiorly, there's relatively poor symmetry. But there's a long way to go before it falls outside the normative data range. Always remember, there's a lot of anatomic area being averaged in here. Small defects, when averaged in, can actually fall within the normative data range. And I think this is a really fine example. Nice visible wedge defect right here. 2 different OCTs. Let's take a look at it. On the Cirrus OCT, I can actually see that wedge defect on the thickness map. Very helpful. When I look at all the parameters, it's all within normative data range. Now, there is a good degree of asymmetry between the right and left eye inferiorly. We take a look at the spectralis. It actually also falls within the normative data range. And when I take a look here on the GCC, it's pristine in the right and there's a bit of a cut in the left, but it all still falls within norm. But clearly the patient is not normal. And another
Hey, Joe,
example, yeah,
go back
yeah,
to
sure.
that picture there.
Yeah.
This is, just, obviously, I think we've been doing glaucoma long enough that we kind of have to look at the nerve, look at the nerve fiber layer, look at the pictures, do GCC, do nerve fiber layer, do visual fields. But where I'm going with this, if you remember back in the day, they used to say, oh my gosh, you could have up to 50% nerve fiber layer loss before you could get a visual field defect. And I used to say, well, yeah, that's true when you start using percentages. You can have a global loss a little bit superior and inferior and get up to 50%. And, the whole idea was, oh my gosh, if you don't have an OCT, you're going to miss these. And GDX, I think, was back in the day with that might have been their tagline. But I used to argue, I said, look, I can have up to, 1 to 5 or 10% and still get a visual field defect. It all depends. Like in this case, it's very tiny, it's very isolated, it's very focal, and this will probably show a visual field defect, but it's not showing up on the OCT. So just have to use all your weapons when treating this disease.
And interestingly, a couple papers came out a few years ago that compared, and I'm just talking about the cirrus. They compared the cirrus to red-free photographs, which was the gold standard for nerve fiber layer deficits. And they looked at the parameters, the clock hours, the quadrants. The parameter they found most positively associated with red-free photography was the thickness map. They really show up very well. Now here's one, if you take a look, red-free photograph, there's an inferior temporal wedge defect. Nerve itself looks pretty good, but there's a very faint wedge defect. Let's take a look at it on the spectralis. What do we see? It does drop down into the red, not enough to tag the normative database. Now let's take a look at on the cirrus. Everything here is falling within the normative data range. Now the deviation map and the thickness map, it really shows up. And I can tell you, really, with the cirrus, I look very carefully and very seriously at the thickness map. That's like my grayscale. I really like that. Now we take a look on the GCC. Left eye comes out pristine. Right eye has a small wedge defect, but this right here, when we cut off at the horizontal raphe, that is very compelling to me on this device. This is what I call the Nautilus shell. When I see a Nautilus shell on the GCC on a cirrus, it's very impressive to me. I take it very seriously. And we look at them and we put the composites and panel map, you can see it's all one defect. So clearly when we have that Nautilus shell, I think this is a term that I coined for this. When we have that cut at the horizontal raphe, that is very serious to me. When I see the Nautilus shell on a cirrus, GCC, I am extra vigilant, even if the nerve fiber layer seems to be normal. So our take-home points, you've got to have a number of scans to determine, a good baseline and see what is the intra-session noise, because they're all a little bit different. Make sure there's a good signal strength and good segmentation without errors. And doggone it, look at the optic nerve. Look for disc hemorrhages, look for pallor, look for myopic discs, tilted nerve heads. None of this will show up on an OCT. Try to determine the structure function correlate. Visual fields are necessary. And follow all these tests for progression. No current technology is better than the human eye and common sense. Beware of red disease. Don't overtreat a patient, but don't undertreat a patient. Treat real disease, not red disease. Don't miss green disease. And understand the limitations of the technologies. The reproducibility, the resolution, normative database. Understand technologies will come and go. We've had the GDX, We had time domain OCT. We had the RTA. A number of things have come and went. It's everything together. Greg, do you have any take-home points you want to share with the audience?
No, I think you covered it well. We had a question that rolled in here. When you perform baseline glaucoma testing, do you tend to do pachymetry? Other than just obtaining it as an initial reading on cornea thickness, is it really that informative from a glaucoma standpoint? Does it make the IOP reading potentially more reliable?
We'll talk a little bit more about that in just a bit, I believe. It is a measurement of corneal thickness. It conveys some degree of risk for conversion, for progression, but we don't correct for that. But I do get pachymetry as part of my glaucoma evaluations that I think are patients who are really ocular hypertensive or glaucoma. The weak suspects, I generally don't.
Joe, is there going to be more coming up, or do you want me to do a little drum solo on that?
Yeah, let's wait. Let's wait on that, Greg.
Okay.
Changing therapy based upon one bad IOP or one bad field. I think this goes without saying, but I want to kind of emphasize it. You know, medicines don't fail overnight. The 17 or 18 at last visit is not the 30 this time. It is a compliance issue. They may think they use the medicine. They have an old bottle of a PGA that's now not effective, but don't overreact to one bad pressure. Now, a failure of 17 or 18 becomes a 20, becomes a 21, becomes a 19, becomes a 23 over time. And don't make a change based upon one bad, one bad field reading. Here's a patient, we look at it. We've gone from a visual field index of 43% down to a visual field index of 22%. The field defect looks like it's progressed. You may look at this and think, geez, this patient is getting much worse. But the key here is right here. Here, the fovea was off. On this one, the fovea was on. What does that mean? When they're doing the foveal threshold, they have to direct their gaze below the central fixation. No foveal threshold, they have central fixation. At this visit, they look down, they don't redirect their gaze. It just brought the whole field down. You repeat it, it gets better. Also, not getting enough pre-treatment and post-treatment IOPs. You know, here's a patient that I diagnosed with glaucoma. This is my medical record. And pressure is 24 and 18. I intercede. I give the patient a medicine. The pressure is now 13 and 12. Is it good? Is the medicine working? It did lower pressure significantly. Is this good therapy? The reality is, I don't know. That's why we need to look at pressures before treatment and pressures after. Now you take a look and we can see overall the trend is a little bit lower. What I want to point out is there are pre-treatments that are essentially the same as post-treatment. So we can't make a decision as to whether or not a medicine works just based upon one pre-treatment and one post-treatment. We need to see what the trend is. We like to get 2 or 3 pressure readings before we start therapy, and then maybe 2 or 3 pressure readings after we start to see, is it actually working or not working? Sometimes we can abandon a medicine prematurely because we thought it didn't work based upon one pressure. Or we may think the medicine is working beautifully when we just happen to catch them at a trough. So get a few pre-treatment and post-treatment pressures before you make a decision whether or not the medicine's working. Here's a mistake to avoid.
Here we go,
Using the
Joe.
term-
Joe, you'll like this question here. This is, I know, one of your favorites, maybe potentially to answer. It came in as a direct message, and it says, when you're monitoring glaucoma suspects, how many years or normal visual fields and OCTs do you obtain before you decrease the frequency of yearly testing and 6-month IOP checks?
Excellent question. Statute of limitation, 2 years. After 2 years, make a decision. They have the disease or they don't. I've seen patients hang around 10 years as a glaucoma suspect. So my rule is statute of limitation, 2 years. At that point, you've got to make a decision. Also, the question, how often should imaging be done in glaucoma suspects and glaucoma patients? Every 6 months. I think it's reasonable to do that. Field and OCTs every 6 months, maybe every year at the outside, once you know a patient's stable. Greg, what are your thoughts?
Yeah, I mean, I think it's, we're kind of painting with a broad brush here. I think it all depends on your suspicion. I'm gonna put together. I had an extern into my office. She actually did a three of her 3rd year and 4th year rotation back to back, just because of the limited providers that were out there. So she was with me for like 6 months, and we had a bunch of glaucoma suspects come in. I have a guy that's pressure of 32 in each eye that I've been following for 6 years. And I follow him just like a glaucoma patient every 4 months, doing the different testing, doing gonioscopy once a year, OCT, OCTA once a year, visual fields once a year, photos once a year. But I see him every 4 months just because his suspicion of 32 in both eyes and not being treated. So I think it all comes down to of the amount of suspicion. And I've been seeing him for 8 years. So, he doesn't have glaucoma, but I think he can convert at any time. So we watch him closely.
It's 8 years of therapy that you saved him.
Exactly. So that's the point. He's a physical therapist. He gets risk benefits. And so he's like, hey, listen, if you can keep me off of therapy and I don't convert, just think if I would have treated him 8 years ago, I'd have been like patting myself on the back. Look how great I am.
Yeah, there's a number of patients we pat ourselves on the back prematurely because we don't know. Now, here, I want you to make this. Don't use the term narrow angle glaucoma any longer. Strike this from your vernacular. Now, is it a bad term? It's an old term. In my opinion, it's a malignant term. I'll give you an example. Optometrists had seen a cranky old patient for a few years. Patient ended up going to an ophthalmologist who diagnosed narrow angle glaucoma based upon a potentially occludable angle. There was no glaucoma at all. He called it narrow angle glaucoma. That was enough to make the patient try to sue the optometrist and ultimately reported her to the board for negligence. It was glaucoma, but he used an antiquated term. The terms that we want to use: primary angle closure suspect, primary angle closure glaucoma, and of course, our primary angle closure attack. These are the terms that we now use in 2020. And let me define them for you. The most common one that we see is primary angle closure suspect, defined as pigmented trabecular meshwork is blocked by the iris. Now, not everybody agrees how much, but I think most people believe 180 degrees. If you can't see the pigmented TM for 180 degrees, this is a primary angle closure suspect. This is a common patient. These are the low to moderate hyperopes we see all the time. But there's no synechia, disc and pressure are normal. You want to probe for symptoms of intermittent angle closure, of pain, pain at night, eye pain, head pain at night, halos around lights. Very, very hard disease to diagnose. We don't know if LPI or observation really is better for this group. Primary angle closure is virtually the same thing. You get the pigmented TM not present for about 180 degrees or more, and they have either synechia and or elevated pressure. But there's no disc damage or field loss. It is considered pathologic, and we do iridotomies for these patients. Primary angle closure glaucoma, the pigmented TM is blocked by the iris for at least 180 degrees. They've got synechia and or elevated pressure, and the nerve is glaucomatous, and they've got field loss. And this is pathologic. And of course, we do perform LPI in these patients. And we all know about the angle closure attack, virtually complete apposition of the iris to the pigmented TM. These are people who are very symptomatic. They've got red, painful eyes, vision loss, nausea, maybe some vomiting, corneal edema, very elevated pressure, inflammation, and a fixed mid-dilated pupil. These are people who are going to undergo medical therapy, iridotomy, maybe iridoplasty, trabeculectomy, but there is pretty good evidence that says maybe a lens removal is better for these patients. And this is just a nice summary chart of what I talked about. Mistake to avoid: thinking that LPI is the best management for angle closure glaucoma. We're really beginning to think a little bit differently in these patients. They actually had, we got the results of what is called the EAGLE study. And the EAGLE study basically looked at primary angle closure patients. And what they did is they compared clear lens extraction, removing the lens, followed by medical therapy or glaucoma surgery if necessary, the people who got the standard treatment of a laser and medicines. And what they actually found was removing a clear lens in people with primary angle closure with elevated pressure or synechia or glaucoma, they actually did a lot better. They needed far fewer medicines compared with people undergoing LPI. And only one person who got lens removal needed trabeculectomy, whereas a number of patients in the LPI actually needed trabeculectomy. And they came to the conclusion that in the EAGLE study, removing the lens was a very viable option. Even a clear lens, taking it out, was actually a better outcome for these primary angle closure patients. And even patients with acute attacks, lens removal is really more effective than the iridotomies. Now, essentially, you want to quiet the attack, get the pressure down, get it on pilocarpine, and get the lens out. And people who have pressure greater than 55 from angle closure, if they're undergoing phaco emulsification, that is a much more definitive treatment than doing LPI. Even though LPI is pretty easy, getting the lens out is going to make really probably the most difference. So if you recognize the importance of lens removal, you're doing it right. You're doing well. You're advising patients well. The EAGLE study clearly showed that lens extraction was preferable in managing chronic angle closure. And in acute angle closure attack, probably the best therapy is break the attack medically, and within a month, get the lens removed. And they're going to do a whole lot better than patients undergoing LPI. That brings me to zap or not to zap. That is the question.
So Joe, while you're moving and transitioning to zap or not to zap,
yes,
we got a couple questions here. So let's take care of the one that's kind of angle closure. Then we're going to be circling back to a previous question. It says, do you get post dilation IOPs on suspects?
On suspects, like angle closure suspects, generally yes. Now the question is, do we dilate them? Now the reality is we do, unless we think the patient is an extreme risk. We're going to talk about that in just a bit. Dilating really doesn't hurt those patients. But yeah, I would check a pressure afterwards. And what's the other one?
The other one is, it says, I'm confused. For example, a patient with a large cup to disc ratio, family history, thin corneas, and let's, dot, 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 meaning this patient is a glaucoma suspect, but has 2 years of normal testing, is no longer a glaucoma suspect. We will miss if we don't keep tracking if they convert glaucoma.
What we're going to do is we're going to see them on an annual basis. But after 2 years, they've got thin corneas, large CD, family history. We're still going to see them for annual examinations. Now, they can become a glaucoma suspect again, or they can convert to glaucoma. I'm not saying that 2 years we're done. But let's say after 3 or 4 years, now a patient comes in with a pressure of 24. Well, then we start over again. What I'm saying is everything normal 2 years, they're no longer really at risk. Now the ZAP was the Zhongshan angle closure prevention trial that actually looked at patients with primary angle closure suspect, trying to decide what is the best thing to do. Does LPI help? Is it necessary? And what they did is they took a large number of patients who were angle closure suspects. One arm received LPI, the other was observed. And what they looked at was to determine, did they convert to glaucoma? Did they undergo an angle closure attack? Did they develop elevated intraocular pressure? Did they develop synechia? And what they found was about 4 compared to 8. 4,000 eyes per year got into trouble. Now, what kind of trouble do they get into? Most of them develop synechia. They were still asymptomatic. Only a few patients actually went into an acute angle closure. So based upon this, what they determined was laser iridotomy did reduce the risk of developing elevated pressure, developing synechia, or having an angle closure attack. But it was a very low risk. So their conclusion was it really was not even justified. Now, what about the patients who you worry about dilating? Well, they actually looked at this. They found out the pulse dilation pressure elevation was about the same if they had an LPI or not had an LPI. So their conclusion was routine LPI before dilation for angle closure suspects was not recommended. And I don't know about you, Greg, but I do dilate these angle closure suspects. How about you?
Yeah, I do. The best thing I think we could do for them is warn them if they close, get them the treatment that they need. I think we just need to be aware of it. And maybe give those people your cell phone if you're on call and you use that method, just in case they do have an issue, because the best thing you can do is break it and then get them treatment.
Here's a patient. She's a 74-year-old female, comes with blurred vision. She's a high hypero. She's got a pretty dense nuclear sclerotic cataract in the right eye. Her pressure was 30 and 25. Monoherically, she had 8 narrow angles. Gonioscopically, she had no structures seen in her right eye and only a little bit of anterior TM in her left eye. Otherwise, no other structures. Now, I didn't dilate her. I couldn't view the fundus undilated. And she looked like this. And we can see on OCT, she's got a very shallow anterior chamber and a very, very narrow angle. She's at about 5 degrees and about 7 degrees. So the question is, what is our assessment and plan on this woman? So it brings me to polling question number 6, Craig. What's the best diagnosis for this patient? Is it acute angle closure, chronic angle closure suspect, or I'm not sure, that's why I'm here? There are her OCT images, very, very narrow and shallow. Blurred vision or otherwise asymptomatic, dense cataract, pressures 30 and 25. So a lot of people weighing in.
A question came in here, Joe, while this is rolling in. Should you have the patient sign some sort of documentation listing potential angle closure prior to dilating to cover yourself in the event you don't work at an MD/OD clinic? And I don't work at it, and I don't work at an OD/MD clinic. So I do have an MD that comes in once a month that takes care of our surgical patients and can do laser PIs and different things, but I don't work at an OD/MD clinic.
And even though I do work with optometrists and ophthalmologists, I'm never in an office with where they are. I mean, I have access as are my colleagues, but we're never in the same office.
So what about the documentation or a waiver or signing something, Joe?
It is the highest level of protection for yourself. I think if you just document in the charts, it's sufficient. But if you have them sign, that is the highest level of self-protection. So we're going to end the poll and share the results. A lot of people call it primary angle closure suspect. I don't think we're going to consider this really to be acute. So really put this in the chronic angle closure because the pressure is elevated. I don't know if it's glaucomatous or not because I can't see the optic nerve. But it's at least a chronic angle closure suspect. Probably angle closure would be good. I don't know if it's glaucoma or not, to be honest with you, because I can't see the back of the eye. So chronic angle closure, I don't know if it's really glaucomatous or not, but there is an elevated pressure. So this is primary angle closure. I sampled from the PGA, set her for a cataract consult. So she goes to her consult, her pressure is 17. Oh, by the way, clinical pearl. Prostaglandin analogs work very well in chronic angle closure. Well documented, many studies. So surgeon made the surgical measurement. He didn't dilate the patient either. Planned cataract extraction, basic ametropia right eye, then left eye, continued present medicines. Patient canceled surgery twice. Don't know why. And you can always lead a patient you can lead an angle closure to osmoglen, but you can't make them drink. So she is chronic angle closure. Hopefully we'll eventually track her down and get her back in for surgery. Now here's a challenging one, backed into a closure corner. 30-year-old female in 2018, before I joined the practice, comes in with narrow angles. Moderate hypo. Rota was very narrow. We can see how narrow she was on OCT. She's diagnosed as a primary angle closure suspect. At that time, 2018, we didn't have the results of the ZAP study, so she underwent an LPI successfully. There's no change. So she was then determined to have Plateau iris syndrome. Now the surgeon discussed iridoplasty, pilocarpine, lens extraction. Didn't really direct her any particular way. He did recommend observation, but said, the glaucoma specialists may have different approaches. You're welcome to give another opinion. He also said, don't start any new medicines without getting his clearance, meaning cold and allergy medicines that could cause a dilation. So she presents emergently to when I'm in the practice in 22, and she has a migraine aura. Now, I don't need the dilator, to diagnose this, but I look at her records and realize there's no resolution to this image. Now, she had forgotten about the medication admonition that had been given her. She started medicine and had used cold medicines. She had been told by another doctor she can never be dilated. She's now worried, doesn't know really what to do. So what do we do here? We see how narrow she is, even after LPI. She's got Plateau iris syndrome. What do we do? Brings me to polling question number 7. Greg? So what is your plan for this patient? Lens removal, iridoplasty, pilocarpine, dilator, see what happens? Or I'm not sure that's why I'm here.
We had a colleague, looks like said lost sound, but I haven't lost anything and I don't see any other reports. So that could be something on your side there, Amanda, unless I get some other people reporting.
So what are we going to do for this patient? She's got Plateau iris syndrome. We take her lens out. Do a uncomfortable procedure that doesn't always work called iridoplasty. Put her on pilo. Drop her, see what happens, let it rip. So people say, take her lens out, pilo, iridoplasty, or droppers. See what happens. Can this 30-year-old go the rest of her life without dilation? Probably not. Are there really any great options? Pilocarpine in a 30-year-old, that's not going to work very well.
Stop.
Iridoplasty doesn't usually work very well.
Get out of here.
I also saying.
You got
Got it.
Thank you. Do you really want to take her lens out at 30 years old and make her a pseudofake? She hasn't had an attack in about 4 years. So I actually quoted Harry Quigley, noted glaucoma specialist. He said, you just don't know. So sometimes you got to bite the bullet, dilate, and see what happens. But you don't do it Friday at 4 o'clock. You do it Friday at 9 o'clock and tell them they're going to be here until lunchtime. So we had this discussion. I give her all the credit in the world. I said, look, I'm going to put some drops in your eyes. You may have to get into a really bad problem. We may have to do emergency surgery. And she came back, comes back at 8:30 on a Tuesday. I dilate her. Her initial pressure is 22 at 8:30. We talk about risk. I used a 0.5% tropicamide because I want that mid dilation. I can calm again and Diamont's ready. It works, trust me. Pressure was 22 at 9:30. I let her go. So come back after lunch. Comes back after lunch, pressure 22 and 23. Pupil in the worst possible mid-dilated state. Nothing changed. Fundus is normal. Educated signs, symptoms, or acute angle closure. Call me immediately. Otherwise, we're going to follow randomly. Sometimes you bite the bullet. Mistake to avoid: thinking that glaucoma causes collateral disc vascularization. I'm going to speed through this one. It doesn't. Collaterals are just these pre-existing anastomotic communications to move blood from one occluded area to another. It's usually retinal venules to choroidal venules, or retinal venules to retinal venules. They're not shunts. They're not optociliary. They're like the high occupancy lane on a highway. If there's no traffic, it's not open. If there's traffic, it's open. We've all been told that this will occur from vein occlusions, from optic nerve sheath meningioma, and glaucoma. The glaucoma part is an urban legend. There is no venous stagnation in glaucoma. It's just patients with glaucoma and with vein occlusions are often the same patients with same risk factors. This was one of my glaucoma patients that, you take a look at those collateral vessels that just showed up. In between here, the patient had an asymptomatic vein occlusion. It's not glaucoma, it was the vein occlusion. But very, very briefly, I'm going to let you take this while I give my voice a rest, but very briefly, just talk about your theory, why you don't want to change your pachymetry readings based upon, or your IOP readings based upon pachymetry.
Okay. So Joe has here, correcting IOP based on pachymetry. And I think that was earlier in the webinar here, or interactive distant learning, is that the key is we don't want to assume that a 600 cornea is rigid and a 500 cornea is mushy. The cornea, as we know, is a very complex, it's a very complicated tissue. We have cornea hysteresis, we have cornea rigidity, we have corneal curvature. I mean, there's probably 20 some different biomarkers or measurements to the cornea. And we take a transcornea IOP with a Goldman tonometer, and then we assume a 600 is, oh man, that must have been really tough. So that cornea IOP that's 23 must be 20. Well, what happens if that cornea rigidity is mushy? Or the opposite? What happens if a 500 cornea is rigid? So long drawn out story. Joe has heard me say this multiple times. Do not adjust IOPs up and down based on pachymetry. One of the keys is that if it's a 500 cornea or thinner, it's a little higher risk. If it's a 600 cornea or thinner, it's a little bit lower risk, and something in between really doesn't help you. So don't adjust IOPs up and down. I see colleagues when I do live courses, they'll raise their hand and say, my ophthalmologist still adjusts up and down. Great, they're wrong. Don't adjust IOPs up and down. So it's just a risk factor. And the key here is, remember, they have to have ocular hypertension. If you have someone that comes in and have a pressure of 20 or 21, and they have a thin cornea, they're a poor PRK or LASIK candidate, that person could not be in the ocular hypertensive treatment study. You had to have a 24 or higher. So you got to apply the people that were in that study. So long drawn out way of saying, do not adjust pressures up and down.
Thank you for spelling me, Greg. That was very helpful. I really appreciate it. My voice is beginning to go, so we're going to land this plane pretty soon. Mistake to avoid. This is the finale. Not recognizing the patients who are likely going to do well, and they're not the ones that you think. You can only call a glaucoma patient well controlled in retrospect. If you diagnose the patient with glaucoma and put on a medicine, and the medicine takes the pressure down from 30 to 15, you may want to say well controlled. Well, all you can really do is say the therapy lowered pressure by 50%. Now, in 5 years, if nothing has changed, you can say, oh, the patient really was well controlled. Some patients are going to progress slowly without treatment, and some progress rapidly even with treatment. And you don't know who is who until you follow them over time. As I always like to say, you might be Keith Richards, you might be Keith Moon. Two people who had a very hedonistic lifestyle that was prone to an early death. One person died early as expected. The other guy is still on tour. So you might be Keith Richards, you might be Keith Moon. You don't know who's who until you follow them. Here are patients I worry less about, and they're not the ones you might think. He is a 66-year-old male, starting pressure 58, average pachymetry. He's 20/30 in the right eye, not seeing in his left eye due to a previous vascular occlusion. You see his visual field in the upper right, that's his 24. We see his baseline 10-degree field. Ultimately, I get him on a stepped regimen, including bromonidine, gozolamide, timolol, latanoprost, and yes, pilocarpine. I used to call this glaucol. This is before we had Rho kinase inhibitors. His pressure on these are 14. Now, these patients with very poor, very, very small fields, high price, they actually do very well in pilocarpine. 1%, 2% twice a day. It will give you 3 or 4 more pressure point reduction. Nowadays, I probably try a Rho kinase inhibitor first. As we see what happens to him over the course of time, 2 years that I followed him, he showed no change. Now, this was good here. He had a very high peak IOP, 58. He had an exceptional pressure reduction of 75%. When you take these advanced disease patients and significantly lower their pressure in whatever method you use, and you keep them low, they will do well. 61-year-old male, pressure of 30 with average pituitary, on latanoprost and zozolamide timolol, pressure of 12. You can see he's got a very compromised neuroretinal rim and a very large wedge defect inferiorly. On a 10-degree field, we can see he's encroaching fixation. We take him down from a 30 down to a 12. Over the course of 5 years, they followed him. What's happened to his visual field? Nothing. What's good about this patient? A high peak pressure, excellent pressure reduction, about 60%. You get the pressure down 50% or more, these patients really do well. Here's a 53-year-old male, peak pressure 32 in the right eye, 43 in the left eye, very thin corneas, a bad sign. Now, on latanoprost alone, his pressure comes down to 15 to 18 in the right eye and 18 to 22 in the left eye. Now, and he had a dorzolamide for a few more pressure point lowering. Now, what do we notice here? His visual field over the course of 4 years really doesn't change. His right eye doesn't change at all. So what are the good features here? The good features are he had a very high peak pressure. He had a significant pressure reduction with just one medicine, and he's on a very low pressure load. These are all very, very good. Now, I just want to stop back for just a moment or two and point something out. This one, you can see kind of a little bit of a sclerotic vessel right there. But in this patient, you see a very sclerotic vessel. Is this a patient who has something else going on? Is there some other disease? Does he have a vascular occlusion? The answer is no. This is how the arterioles are supposed to look. It is pseudosclerotic. If you see this in a patient with glaucoma, with very, very dense or large nerve fibrillary defects, your ability to see that vessel is altered by the fact the nerve fiber layer is atrophied. All the arterioles should look sclerotic like this, or pseudosclerotic. It is not really sclerotic. It is indicative of a broad area of diffuse nerve fibrillary atrophy. So always consider that, in your patients. It's a little bit of a clinical pearl. 63-year-old female, glaucoma for the left eye for 5 years. Interesting, this is a patient who was in a true normal tensive range. The pressure range from 14 to 18 in the right eye, 15 to 18 in the left eye, with an average pachymetry. Now, this is a patient with unilateral disease, but symmetrical pressure. The visual field loss does not threaten fixation. We had a conversation together, and the patient actually elected to be observed carefully over time every 6 months. Now, one thing that's quirky about this condition called normal tensive glaucoma is the fact that these are people in the true normal tensive range. They tend not to get worse, or they tend not to change very quickly, even without treatment. And that was actually seen in the normal tension glaucoma study. Greg, what are your thoughts here on the normal tensive glaucoma patients?
I was muted there, Joe. Sorry. My thought is normal tension glaucoma, if this is where you're going, is that, they're to me, they're the same thing as primary open angle glaucoma. I think you and I have both sat around and chatted about, we don't call people high tensive glaucoma or elevated tensive glaucoma. Normal tensive glaucoma patients are basically primary open angle glaucoma patients that are glaucoma. If you think back to how you've got your normal range of IOP, maybe Joe, the history, but in my mind, it's, we took a bunch of pressures, gave it to statistics people, and we found out that the mean was 16. And just like we do in medicine, we go 2 standard deviations, 1 standard deviation, 2 standard deviations, we get 10 to 21. If we get to 10, no big deal, but whether the disease is associated with around 21 or higher is glaucoma. Well, that's based on statistics. So, you could have someone 20, you could have someone 21, you could have someone 19, just because it's a statistical analysis under 2 standard deviations, capturing whatever 98% of the people. So that's why you can have people that have pressures of 19, 20, 21 that are normal tensive, that are out there, maybe with other risks and comorbidities of sleep apnea and other conditions, but maybe that's what's putting them at risk. But to me, that's normal tension is the same thing as high tension.
Yeah, but the interesting thing about these true normal tensive patients is a lot of times they don't get worse, or they certainly don't get worse fast. So
Correct.
what I like about this person, she was truly in the normal tensive range, moderate disease, not threatening fixation. And over the course of how many years, she really didn't show any change. Now, I will say probably after about 5 years, she did actually show a little bit of change. And at that point, we did intercede. Now, here's our last mistake to avoid: not identifying patients who are likely not do well. Which ones are the ones truly at risk? Now, if you looked at the other ones I just showed you, these were advanced disease patients who did not trouble me as much as the ones that are upcoming. So watch these patients. They're not the ones you think. Who are the ones that represent unsuspecting danger? The ones that are having a good time at the beach. You're out there, the water's nice, you don't realize you're between the breakers, and that's where the sharks are. 65-year-old male, peak pressure 22 and 29 with average pachymetry. I followed him for about 7 years. Ultimately, I worked him up to latanoprost, timolol, and brimonidine. His pressure comes down to 15 and 14. Now, he's ocular hypertensive in the right eye, glaucomatous in the left. Right field is normal. Left field, we've got the defect. You can see the asymmetry in the cupping. Now, how long did it take me to get, to all these medicines, which were at that time his maximum tolerated medical therapy? About 3.5 years. So what don't I like about this? His peak pressure is not terribly high. Okay, 22 and 29. A very short duration to a maximal medical therapy of only 3.5 years. We had an admed. He had a very high load of medicine for modest pressure reduction. 22 only down to 15, 29 down to 14. It took a lot to get there. Now, his field unchanged, it didn't change in the time that I saw him, but he did have a disc change. And this was always the kind of person I worried about. Now, this is a woman I really, really worried about. I probably followed her for close to 20 years. I don't know what her peak pressure is. She's been treated since she was age 35. She's 55 now. She started on timolol with thin corneas. She had a disc change, amplified her therapy. Pressure elevated, amplified her therapy. She had a field change, amplified her therapy. Ultimately, get her to latanoprost, timolol, and brimonidine. She's at pressure 15. So I followed her for about 15 years. We can see she's got compromised rims and very broad nerve fiber layer defects. We can see her visual field there, and she did have some changes. So what do I like about this? Young age, long duration of treatment, 20 years, and she's still very young. She's on maximally tolerated medical therapy, and she's got a thin cornea. These are all things that troubled me about her. And I always, nicest woman in the world, couldn't have been sweeter. always was very worried about, always liked her, always enjoyed her as a patient, always worried about her. Then at a pressure of 15, her visual field starts to change. So even though she's at 15, she's getting worse. Now, because of insurance, I had difficulty arranging surgery. And in the area at the time, I didn't want to go to a glaucoma specialist who's going to do an SLT or put an eye stent in and not really do anything. She needs real glaucoma surgery. Then she had to leave the country for 4 months to care for her dying mother. Okay, so the last thing I did, I switched her latanoprost with Rocklatan, kept everything else there, and then got her to a pressure of 9 and 10. And even though I've left the practice and my protege has inherited her, she said at a pressure of 9 and 10, which she's maintained with these medicines, she is stable. But after 15 years, a pressure of 15, she got worse. Again, young age, long duration of treatment, maximum medical therapy, and a thin cornea. 53-year-old female, multiple disc hemorrhages, peak pressure only 20 and 22. That really troubles me. Central corneal thickness is a little bit on the thin side. Her treated pressure, 12 to 15 and 12 to 16 ranges in there. Brimonidine, latanoprost, zolamide, timolol. She's had recurrent disc hemorrhages and she has had field changes. What don't I like here? The low baseline pressure. That's troublesome. Maximum medical therapy to get a modest pressure reduction from 20 down to 15, 22 down to 16. That's not great. And of course, she had bilateral recurrent disc hemorrhages, a risk of getting worse. She is getting worse, and she had field change. What bothers me the most is the low baseline pressure. These are the people who are, I think, at most risk of getting worse if we don't get the pressure low enough. 60-year-old female, glaucoma followed for 11 years. Again, peak pressure, only 20, average spirometry. Zolamide, timolol, latanoprost, pressure down to 15 and 14. Not a lot of pressure reduction for a lot of medicine. What happened? She also had recurrent disc hemorrhages, and she changed over time. So what is troublesome here? Low peak or low baseline pressures in that low 20 range, modest pressure reduction, a lot of medicines, and of course she did change. She ended up getting surgery. Well, those last two patients not be considered low tension. Now they're in the low 20s. Yeah, once I go over 20, I don't consider that in that true normal tense of 13 to 16 range baseline. What percentage of POAG 50 to 60-year-old patients will lose significant vision in their lifetime if untreated? Greg, I don't know if I feel I can give an accurate answer. I'm going to say, in my opinion, it depends. Probably 15 to 20%. Your thoughts, Greg?
Yeah, I wasn't sure where you were coming with that. Now I see the question in there, Joe. What percentage of 50 to 60-year-old patients will lose? I was trying to, where is he coming from? Will lose their significant with a lifetime if untreated. Oh, wow. Yeah, that's a great question. Problem is, I don't, how do we answer that? Because how many people have gone a lifetime without treatment? I don't know. I think your number is pretty accurate.
Maybe if there's a difference with pressure 25 or 50. A good question is, what percentage of POAG patients 85 years or older will lose significant vision in a lifetime if untreated? I'm going to say probably 2 or 3%. Now, things that give me comfort. My wife, my cats, my dog, kittens, Bunny, and a good bourbon. These are all things that give me comfort. What else gives me comfort? A high initial peak pressure. Give me 30s or 40s rather than low 20s. I can work better with it. You can get a more significant pressure reduction easier. As Greg always says, it's easier to lower a high pressure than lower an already low pressure. Give me a significant IOP reduction, regardless of how bad the disease is. You drop them by 50%, you bought them almost untold amounts of time. Give me good initial pressure response to one medicine. A prostaglandin with a 35 to 50% pressure reduction, wonderful. If we can keep them on one or two medicines only. Now, if we start with a very high peak pressure, we get a significant pressure response to our therapy, that's like kittens and bunnies. That is fabulous. Those people will do well. Things that make me uncomfortable: stinging insects, heights, and scary evil clowns. These are all things that make me uncomfortable. What else makes me uncomfortable? Exfoliation. It's a bad disease, but it's like a stinging insect. I can manage it. Disc hemorrhages. The patient showing change. We can manage it. It's a stinging insect. A rapid escalation in therapy, adding 2 meds within 3 years, troubles me. A low peak pressure, the low to mid teens is probably not so bad, but low to mid 20s is where it is that uncomfortable zone. That's a hard zone to work with. A poor initial IOP reduction, especially to a prostaglandin, and they're using it, doesn't bode well. It's like heights. Now, if you got a low peak pressure, like a 22, and a poor pressure reduction with a prostaglandin, you get down to 19 or 18, that is scary evil clown territory. That's a patient who's not going to do well. And you can be cruising along with pressure of 17 or 18 and think you're doing well. But if you remember, you only started with a pressure of 20, you really haven't changed the risk factor all that much. So that's where we have to worry. So I'm going to wrap it up with what I call my ode to glaucoma treatment. When the pressure starts high and the treated drop great, likely a good outcome is to be the fate. Compliance, exploration, and disc hemorrhage must be watched so the case doesn't get botched. Most patients can be predicted, and you then won't be afflicted. Now, some patients will surprise and cause your blood pressure to rise. Lowering 22 down to 18 is not enough. Check for 50% so that they don't snuff. So with that, be aware of the gray area in glaucoma where the dangers may be lurking, and may you have nothing but kittens and bunnies. So with that, Greg, I am done. Thanks for him, Greg. Really did appreciate it.
All right. I think I'm sharing my screen now, right, Joe?
You are. You are.
Perfect. So I don't see any other comments, Joe. I lost it when I shared my screen. So if you want to check to make sure that there's no questions, I want to thank you. I think that was great. You know, your title matched the lecture well, mistakes to avoid in glaucoma management. We can truly see that this is your expertise and one of your passions. So thank you for doing this tonight for Optometric Education Consultants.
And thanks to everybody who attended. We really appreciate that. We know, you got many choices for education, so we thank you for being here, and that's why I try to persevere. Hopefully I didn't sound too badly with my voice, but I know you committed to this, so we had to be here if at all possible.